nurse. I work at UCSF. I am the clinical lead of mechanical circulatory support, which is so MCS. It's just a big word for pumps. Okay, so we deal with pumps inside of the body and pumps outside of the body. We're going to talk about left ventricular assist device today, our pumps, implantable pumps, long-term pumps inside of the body. But we also do, if anyone's heard of ECMO, we do ECMO. You come over here sometime to St. Mary's and put people on ECMO. So, sorry, it's something that we do. And we have a small department. There's just 4 of us, and we report directly to our surgical and medical directors. And we take care of about, we take care of the patients in the hospital who are on ECMO. This is a form of life support that you can only be on in the ICU, and it's for if you're in profound heart or lung or both failure. The VADs themselves, these are patients with end-stage heart failure that get implanted with these pumps, we'll talk about that in a minute, and that go home. And so there's anywhere between 60 and 70 at a time just from our center. So Stanford also does them, CPMC does them, Davis does them. So these patients are all over the place. You're just not quite as familiar with them. But you will be. In 10 years, it'll be like on a pacemaker. Everyone will know what that is. I'm going to show you, so just correct me, Marilyn, what's the time frame for this group?
For this group is 2 hours, but if by any chance,
Okay.
if by any chance you can minimize that, I can bring in a few more people for the assistant. That way you can sit there, but there might be more people coming too.
I'm going to show you 2 videos. One's a little older and it's a little cheesier. In this video, though, it does a really nice overview of like why patients get this device and what it does. And it's, someone said, you had a guy here before, the guy that turned his VAD off or chose to have his VAD turned off. This is the pump that he had. So the pump that your patient that's coming this afternoon has is a slightly different pump. But like I said, it's like the difference between the Android and the iPhone. It's basically the same. It's just that the stuff on the outside is different. Different company makes it, okay? So I'm gonna show you this video, it's a little bit longer. And then I'm gonna show you a second video that's specific to this pump or the hardware, which is what your patient has. I'm just gonna make sure you have volume. And then, is there video, is there audio on your system?
Ellie?
I believe so. I don't know.
Camera.
I mean, all signs better.
Are the subtitles?
Sorry.
Several languages.
Try the volume on the remote control.
Oh, okay.
Right, yeah, see if that helps, maybe.
Here we go.
Thank you.
Thank you, Tamara.
It really comes down to very,
Okay. Cheesy guitar music.
I tell everyone to listen about this device because it saved my life.
it really comes down to very, very basic things. Either you want to live or you want to give up. And I just very much wanted to live.
When I woke up from surgery and felt so full of life and energy, I knew I'd made the right decision.
Main thing, I'm able to get up and I'm able to go.
I can't say enough good about it.
These people are talking about their decision to have an implanted heart pump to treat their severe heart failure. The pump is commonly called a VAD, short for ventricular assist device. This type of therapy is sometimes referred to as MCS, or mechanical circulatory support. For the right person, a VAD can mean a longer life with improved quality of life. However, the decision to have a VAD is one that should be considered very carefully. This video will help you make an informed decision about whether a VAD is right for you or your loved one. A normal heart efficiently pumps blood throughout the body. With heart failure, also called congestive heart failure, the heart may enlarge and its ability to pump blood becomes impaired. It is usually caused by a failing left and/or right ventricle.
Your heart is basically a muscle. It's a muscle just like your biceps or your triceps or your leg muscles. And when you use your heart a lot, or your heart becomes damaged from the myocardial infarction, meaning a heart attack, or long years of hypertension, a virus, or idiopathic, meaning it just happened, the pump function is limited. So the actual pumping function of the heart to the body is decreased, meaning the body is seeing less blood flow. Symptoms typical of patients with decreased pump function would be shortness of breath when they lay flat, waking up in the middle of the night with shortness of breath, decreased ability to walk 1 or 2 city blocks or go up a flight of stairs easily.
I had 2 quarts of milk to carry, and I remember that I couldn't carry them together. I had to make 2 trips to my car, carrying 1 quart at a time.
I had a hard time going upstairs, downstairs with the medication. I thought it would get better, but it just got worse.
When I went up and down the stairs, I had to take deeper breaths. Just standing up in one spot was very tiring.
A ventricular assist device, or VAD, such as the HeartMate, assists the failing heart by taking over the function of the diseased left ventricle and pumps blood out to the body. It can restore blood flow and allow the heart to return to near normal size and shape. With increased blood flow, the liver and kidneys may also return to a more normal condition with significantly improved function. A number of different VADs are available for circulatory support. Your doctor will suggest which one may be the right choice for you.
A ventricular assist device, or mechanical support device, actually is implanted surgically, and it takes over 90% of what your heart should be doing. Your heart will still pump. It will beat. It will have a rhythm. It will still be working. It just has to do the 10% it's doing, and the pump assists the rest.
For some patients, a VAD may be used as a temporary therapy while the person awaits a heart transplantation. This is called bridge to transplant.
Some patients aren't candidates for transplantation. Some patients, transplantation is a marginal therapy. Some patients are too ill to wait for a suitable donor. And some patients really don't think transplantation is what they would desire.
For non-transplant patients, VADs can offer long-term support.
Patients have done well enough on it that it's now something that we use as extended therapy for patients.
People being considered for a VAD will undergo tests and procedures to find out if it will benefit them.
Specifically, what the pump does, once it's surgically implanted, is it sits below your heart, under the diaphragm, in your abdominal cavity, and it's implanted. It's inside you. The only part that's external is the drive line, and that's the only thing that you have to take care of. You will then be dependent on some electricity, whether it be batteries or whether it be a unit in your home, but you're completely mobile.
A person with a VAD is always connected to either a power-based unit or a pair of battery packs.
Well, I can't be very far away from electricity. Usually we just go camping somewhere that I can plug the charger in and then take enough batteries whenever we go on a hike.
As far as learning the system, while it was a challenge in the hospital, it's just second nature now. It's simple. I don't even think twice about it. I do concentrate when I'm changing batteries or when I'm going from battery to power. I concentrate on purpose because I can't afford to make a mistake. But it is very much second nature. I don't think about it. I find it easy. It's actually easy.
My girls have been wonderful. They actually call me the electric mommy now. When I was in the hospital one time, and they kind of were still getting used to seeing me drag the cord around when I was going to use the bathroom. They kind of would take a double take at it, and whenever one morning said, "Oh, you're an electric mommy now," and they kind of coined that phrase.
Okay, so like the video said, so a VAD is just a pump. So here's what I want you to imagine: a jacuzzi pump. right? Put your hand in front of the jacuzzi jet, that's all it's doing. So the pump is just sucking fluid in and blowing it out, okay? So it's just taking it from one area and moving it to another area. So a VAD, ventricular assist device, is just a pump. So we call it an LVAD because it's placed on the left side of the heart, okay? You can have an RVAD or you can have BiVADs, a pump on each side, right? And you can have temporary VADs, which are actually the pumps are on the outside, which is what ECMO is. But basically, so VAD just means pump, okay? So its whole purpose is to take blood that's not moving and to shunt it to where it needs to go, okay? So it bypasses the weak left ventricle. So if you guys ever read in an H&P that the EF, or ejection fraction, is 10% or 15%, you ever read that in a cardiology report or an echo report? So the left ventricle is only getting out 15% of what it should be getting out, right? And so that's why the person's in heart failure, right? So heart failure, the very definition of heart failure is my organs aren't getting the blood flow they need, right? So when you're in heart failure, your brain doesn't work as well, your kidneys don't work as well, so you get kidney failure, and sometimes you go on dialysis, you have liver failure, you have like a lack of blood flow, you're super fatigued because your muscles don't have enough blood flow to basically live, right? So if you think about what end-stage heart failure is just a lack of blood supply to the major organs of the body, right? And so what the VAD does is it lets the ventricle sit there and do that. So let's say the EF was 15%, it's going to do the 15% it was doing, and the VAD is going to do 85% of it, okay? So the VAD is like a hole is poked, and you'll see this in another video, a hole is poked in the bottom of the left ventricle, the VAD or the pump is put in there, right? And the outflow then goes to the aorta, which is where the LV would be pumping if it was pumping well, right? So now, LV is still gonna pump, gonna do its little 10%, right, or 15%. Now the VAD is gonna and take that blood that's sitting there in the left ventricle, not going anywhere, and shunt it into the aorta. So now the patient goes from having an EF of 10% to having an EF of 10% and 6 liters a minute in the aorta. So it immediately decompresses their heart, right? Does that make sense? All right. I'm going to show you one more video. It's shorter. It's a little slicker. It's like trying to sell you the VAD. But I feel like it really depicts perfectly the path of blood through the heart and the patient's system, and so that you can sort of visualize what's on the inside and then what's coming out on the outside, okay? So this is the video. Even if patients are going to get that pump that you just saw, the HeartMate 2, I show their families this video because it's so, I feel like it's so good.
I'm Hall of Famer Jerry West, and my life is basketball. But that doesn't stop my atheism from leaving.
Caution. United States federal law restricts this device to sale by or on the order of pump with integrated inflow cannula, an outflow graft with strain relief, a drive line, an external controller, and external power sources. At the core of the hardware platform is a proprietary suspension system for the wide-bladed impeller. Using a combination of both hydrodynamic and passive magnetic forces, a thin layer of blood is established between the impeller and the pump housing. During operation, there are no points of mechanical contact within the pump, effectively creating a wearless system. The HVAD pump, roughly the size of a golf ball, is capable of providing up to 10 liters per minute of blood flow. Its small size and integrated inflow cannula allow the device to be implanted completely in the pericardial space directly adjacent to the heart, thereby avoiding abdominal surgery. The implant procedure makes use of a proprietary sewing ring and custom apical coring tool, which allow the pump to be attached to the apex of the left ventricle. The outflow graft is then attached to the ascending aorta. Once in place, blood flows from the left ventricle through the inflow cannula into the impeller. It then exits through the outflow graft to circulate throughout the body.
Okay.
Very cool.
It's really cool, huh?
Usually, this patient on blood thinners or?
Yeah.
Okay.
Okay, to review path of blood again, right? So all the blue blood, all the venous blood that's been extracted of all the oxygen, right, has been used by our organs, and it's all coming back, right? It's draining from our head, and it's draining from our lower extremities, and it's all coming back, right, to the vena cava into the right heart. So the right heart's just a big warehouse for used blood, okay? So it goes into the right atrium, goes into the right ventricle, and when the heart beats, the blood that's in the right ventricle goes to the pulmonary artery to the lungs, and that's where it gets oxygenated, right? CO2 goes out, O2 comes in, and then it goes back to the left ventricle. Well, this is why the RV doesn't have to be that strong, right? The RV is pushing against a low pressure system, right? The blood pressures in the pulmonary artery aren't like 120/80. They're not like they are in the aorta, right? And it's not very far to go, right? If you think about the left ventricle's gotta get the blood everywhere, right? And the RV just has to pump it here to the lungs and then back. Now, all that oxygenated rich blood that just got, worked over in the lungs, right, is now coming over, sitting in the LV. That's where, like, this is where the rubber meets the road, right? And this is where patients in bad heart failure are congesting or backing up. That blood is backing up, back into the lungs and back into the right heart, right? So now you put a hole in the bottom, stick that jacuzzi pump in, right? And then, so that's inflow, right? And then the outflow, the surgeon attaches to the ascending aorta, right? And now you turn that thing on, and it takes that big amount of blood that's been sitting there, dilating the heart, making it big and boggy, right? You decompress it, take that volume away, and now you just shunt it, right? So if you think about patients, if you've ever read patients who have heart failure, the American Heart Association classifies it into class 1, 2, 3, and 4. 1 is I've been diagnosed, but I don't have symptoms. All the way to class 4. Class 4 is I have symptoms with maximal therapy. So I'm on all the best medications I can have. Like maybe I've got AICD pacer, Biv pacer, right? I go to I'm on diuretics. I go to clinic. I do everything I'm supposed to do. And so I've got maximal therapy, right? And I have symptoms at rest. Okay? So the guy I think about in class 4 heart failure is a guy, like a couple years ago I met, right, sitting in the ICU cardiac ICU over at UC, and I went over and met him the night before his surgery, like, oh, hey, I'm Michelle, I'll take care of you after your surgery, right? And he's watching the Golden State Warriors. This is the first year that they were in and he's sitting, now he's in an ICU, right? He's on dobutamine, he's on heparin, he's on INO, he's like, he's got a cordis in his neck, he's just like hooked up to everything. He's sitting in like a high Fowler's position in the chair, and he's watching the basketball game, and it looks like he's playing basketball, right? That's how heavy he's breathing. So he's not doing anything, and he's like just to be alive, that's what it takes, all right? So if you take, so people with class 2 heart failure aren't getting VADs, right? You have to have class 4 heart, it's the end of the road, right? And it's progressive one way. It's not like you get cured of end-stage heart failure, or you like cut it out, right? So you're at the end of the road, okay? You take this, you put this in, after about 3 months, it takes them back to class 2, right? So now they still have heart failure, but they're in way more manageable symptom territory, where they can go out, they can go back to work, they can do the things that they were doing, they can take care of their kids, they can whatever they do, right? Does that make sense? All right. So obviously it requires open heart surgery. So all that is on the inside, and the cord comes out.
Exits the patient's skin and connects the implanted pump to an externally worn
So
controller.
all you see is the cord.
The controller is powered by 2 lithium-ion batteries, or 1 battery plus an adapter connecting to a wall or vehicle electricity outlet. The controller operates the pump and features a 2-line LCD screen to display parameters, alarms, and recommended troubleshooting concerning the operation of the system. The controller and batteries are carried in a case, designed to be worn either around the waist or over the shoulder.
Alright. Kind of feel like they want to tell you one. Call now.
Federal law, federal
Yeah.
law, federal law.
Wow.
Can you use cell phone while having the pump?
Yeah. Alright, so who gets it? Patients in end-stage heart failure, okay? So someone asked, like, am I gonna see more of these? You're really, so we're already seeing more. So I haven't been in this industry very long. I was a cardiac OR nurse, and then I switched specialties, and I was working in a cardiac ICU over there, so I thought I wanted to go back to grad school and do nurse anesthesia. And so this was in 2007. So I got pulled into this in 2007. So if you think about it, in 2007, we didn't have these newer, what we call these second generation pumps yet, so we maybe did, at UCSF, we maybe did 5 or 6 VADs a year. Now we're doing 60, 70 VADs a year. That's not that long, 2007 to now, right? That's not that long. And if you think about the baby boomers getting older, okay? So you have 6 million people in the US, right, with end stage heart failure, and you have 10% of that 6 million that are progressing into the end stages, class 3 and class 4, right? So, and that's despite maximal therapy. Like, they've got the best treatment money can buy, and they're still progressing to class 3 and class 4. So, and there's over 1 million hospitalizations with people with CHF every year. So there's no, and like I said, it's like you can't like cure it, right? So you have all these people getting older, right? You have an aging population with more and more people advancing to the end stages of heart failure. And let me just tell you this: the 2-year survival in patients with class 4 heart failure is 20 to 30%. So that's worse than pancreatic cancer. Like, if I've got end stage heart failure and you've got pancreatic cancer, you have a better shot of living than I do. Okay? It is not uncommon for us to be working up a patient for a VAD. They're at home, and they just don't show up for an appointment. It's because they died. Wow. They just drop dead. Their chances of spontaneous death are very high. Okay? So if you think about that, you would be like, okay, well then, so why all these people, like, what's the gold standard? The gold standard would be a heart transplant. And why would it be the gold standard is because the 10-year survival is 62%, the 1 year is 88%. So that's why it's the gold standard. So if everyone could get a heart transplant, everyone would, right? Who's got end-stage heart failure. But of course, you've got, right, so you've got 1 million people progressing to class 3 and class 4 every single year. Sorry. And then you have about 2,300 transplants a year. So you have a way mismatch on the amount of people that need hearts and the amount of hearts available, right? So this is what the whole country, the whole world actually is faced with donatable organs, is that there's just not that many organs available, right? Is that lots of people aren't organ donors, right? And a lot of times, even if they are, maybe they've got, their organs are trashed. You can't use them, okay? So if you break it down, what I've just talked about, it basically comes to this, right? If you've got end-stage heart failure, you're either gonna die, you can be listed for heart transplant, but it is very, very common to die waiting if you don't have something implanted, okay? So now, what the common thing to do is, especially in this part of the country, where there really is a shortage of hearts, is to put a pump in. One, you make the patient better, healthier, right? They go home, they're not sitting in an ICU waiting for a heart, right? And two, they don't die. So then they wait. They wait on the transplant list, waiting for a heart.
That's great, because they get stronger before a transplant.
And if you were a surgeon, who would you rather transplant?
Yeah,
right?
somebody healthier.
Someone with a nosocomial infection that's been in the hospital for 3 months on a drip and on dobutamine, or the guy that's like playing golf and hanging sheetrock, right? Like that guy that I want, and eating, right? So that's kind of the breakdown. So when we put VADs in, well, we can classify the reason we're putting them in for 2 reasons. So either they're going to be like a BTT, a bridge to transplant, which your patient that's coming today is a bridge to transplant, okay? Or there's patients like the one you were talking about previously who had come, and I think he was on a vent. He was always a destination therapy. So a lot of times people are too old. They don't qualify for transplant for one of many reasons, right? We put VADs in people that have done meth, right? And amphetamine, right? Because if you think about like 10 years or 15 years of cocaine or methamphetamine uses, it's just like your blood pressure is like 220 over 100 for a long time. And if you think about your LV trying to push against that every single heartbeat, right? It's just like your heart wears out. Right? So you have people that have maybe a 10-year abstinence from the substance but have really bad heart failure because of that. So sometimes those people, their most recent use is pretty recent, like 6 months ago. We're not just going to sign them up for a transplant, right? So they'll be DT, old people will be DT, really fat people will be DT, and that's because they just have to have, a lot of people lose weight and then get on the transplant list, or don't do meth for 2 years and get on the transplant list. So you can go from DT to BTT, but those are the kind of 2 classifications. So we have about half and half, like half our patients of those 60 that I said are old guys. Old guys that just want to live out, another 10 years. They just want to be around with their family, okay? And then the other half are people and anywhere in age of range from 20 years old to about, our oldest is 78, right? But, and our oldest Bridget transplant is 71. So you have then another group that are waiting for transplant. Does that make sense?
I have a question.
Mhm.
How long can somebody live with
The longest survivor right now in the country with the implanted is about at 9 years. That comes though, I'm gonna show you all this stuff, you know, you have stuff on the inside, that pump, we put it in a bucket of water, it's just gonna run and run, probably run forever, or like 20 years or something, right? Cause it's a very well engineered pump, it doesn't have any touching parts, so it just like it's just like going. It's the stuff on the outside, it's like all this stuff that breaks down in life. Like, does anyone have a MacBook at home? How many times have you had to replace the power cord on the MacBook, right? Like, I feel like I buy a new one like every 4 or 5 months, right? So it's the same thing with this stuff, right? This stuff starts breaking down, and also the cord coming out of the patient that's attached to the pump, it breaks down. So you have patients that have been implanted for 9 years, but they may be on their second pump. So we have to go in and do a pump exchange.
So it's more mechanical breakdown of the hardware rather than complication.
Yeah, they can live a long time.
Was it designed by an engineer or a cardiologist?
Both engineers.
And cardiologist?
Yeah.
Okay.
Yeah. So the two systems, the patient that you're gonna get has a HeartWare, which is that second video we saw, okay? But what I'm gonna tell you is, like, you know, in a year, you might get another patient, it might be a HeartMate 2 patient, it might be another HeartWare patient, I have no way of knowing, we put both in, okay? But what I'm here to tell you is both systems are 99% the same. And if you think about what the components of the system are, you've got an implantable pump, right, or an LVAD that's in the left ventricle. So that's that top picture, which is the HVAD, the HeartWare, which we're talking about, but also the HeartMate 2, right? So you have an implantable pump, it's connected to the left ventricle and the aorta, check, both are the same. You have a cord. The cord is called a drive line, okay? So the drive line contains, so you've got a pump inside, and you've got this cord that exits the body on the right. That cord has a bunch of electrical cables and data cables, and they're redundant. So like if one breaks, that's not like the end of it, right? So you have a bundle of cables that are wrapped together and that come out, and that's called a drive line, okay? So both have a drive line that's tunneled out onto the right side, and then the drive line on both of these connect to a computer, and the computer is called a controller, okay? And the computer is how we control the pump. Okay, so we can do with the computer, right, we hook it up to a monitor, but with basically the computer, we can tell the pump how fast to spin, right? So spin 9,000 repetitions a minute, or spin 92, and that's all based on the patient's physiology, is how fast the pump will, you know. And then we can also record data from the pump, or, you know, with the controller, and then it also has alarms on it, right, so we can monitor with the controller. And then the controller from that, so you've got a pump, you got a drive line, you got a controller. Both systems have exactly that, right? And then the controller, in order to work, so here, this pump's on, right? Yeah, that's what it'll sound like too when you listen to her. Zzz. So let's see, can you hear, if you put your head on the table, can you hear it? Yeah, and it's like that if you put your stethoscope on the patient's chest. That's what you hear, right?
Who's doing adjustments?
What?
Who's doing adjustments?
We do, but by the time they're here, you're not constantly adjusting them. It's right. They're settled out.
Are we adjusting them at all?
Nope.
Okay.
No.
And it adapts to exercise when you need more cardiac output.
Mm-hmm. Yeah. So in terms of this system, right, you've got a pump. The pump connects, and her drive line is
This is external pump, right?
Yep. So this is what she's got, okay?
Okay.
So you guys can pass it around, but, okay. Her drive line is clear like this. On my little fake one, it's black, but that's just so I can run, like, this is not what's inside of her. What's inside of her is that little silver pump, okay? This is just so I can run it, okay?
Well, this is what I'll see on the outside.
Mm-hmm. So you'll see a controller, right? And the drive line coming out from the patient's right side attaches to the controller. If the controller is not, if the drive line is not plugged into the controller, the VAD turns off, right? So do you think we ever take the drive line out of the controller?
No.
No.
There's probably a backup battery there.
There's not. So, I'm just telling you that, so like, this is like, I'm gonna talk to you all day, like, I'm gonna talk to you for 2 hours about this, and really, here's the thing. Here's the thing you need to know.
Don't unplug the
Don't
drive
take
line.
the drive line out of the controller.
Never.
And also, the other thing you don't wanna do, right, is, right, so it's going, right?
Mm-hmm.
If I take off, and we'll talk about this in a minute, if I take off one battery, or I take off one source of power,
Still going.
it's no problem, right? Cause it's just like any electrical piece of equipment, it only needs one to go, right? But if I only had one, like let's say I only had one, if I had to change this battery, I'd have to be all like ninja fast, right? I'd have to be like, okay, we're gonna change your battery, are you ready? Right? So I have two, so that I can always have one on and I can safely take one off, right? Sorry, this is, cause it's my mock equipment, it's not acting right. Okay, so, I have
This is clear line in there,
clear,
right? This is
exactly,
clear.
this is
Okay.
clear, okay? So this is inside the patient, clear line goes to the back, where's that thing going around? So you can, right, drive line, alright?
What do you mean? What's inside the patient?
That little silver thing,
Yeah, not this, right?
right,
It's,
And that somehow hooked to that.
right.
That's
So,
just a demonstration.
that's just a,
This is
here,
the
put
pretend
this under your
silver
shirt, put it under your shirt. Under your shirt, alright.
Better be.
So that's where it is, he's got a cord that's gonna exit, wait, this is left. He's got a cord that's gonna exit over here, and that cord is gonna go to here. If I take the cord out, it's gonna stop. Okay? But let's say it falls out, and you hear that. If you just put it back in, it starts going again, right? Alright, no problem, no problem. No problem, alright? So don't take the drive line out.
2 seconds.
Okay, and then here's the other thing you don't wanna do. It's okay to take one off, as long as I have another one on, but if I take both off, the back stops.
yeah.
No electricity, right? So what are the two things I need all the time?
This
And that,
and one of this.
yes,
Okay.
right.
But you can have
Okay.
your patient
So-
criteria for understanding all of this.
What?
The patient will know all this when she comes.
Yeah,
to-
but she's had a stroke. Yep, that's why,
So she
right?
is-
So
yeah.
normally when I come,
Yeah.
like, cause someone had a hip fracture and is here for PT, I don't have to tell you guys about how to switch the batteries, right? Cause the patient is the VAD trained person, but she has had a stroke, right? Ding dong, right? So I gotta train you guys, right? What?
That's my battery.
That's your battery. So I want you, as this thing is going around, practice taking the, so I have like little fake, I have little nubbins on there for you. Take it on and off.
So are there 3 ports for the battery?
This is a data monitor. Like this is if I come, like yesterday I came and interrogated her VAD, and so I have like, it looks like a laptop I bring with me and plug it in here, that's how I get data from
So
it.
that's not.
So 3 things, okay? The 2 in the front are, and we're gonna see slides on this too, okay? 2 in the front, electricity. Can you take one off? Yep. Now I want you to see something. Do you see the lights toggling? So it should be right now, this light should be on, is that right? Is that number 1? Yeah, number 1. Okay, so the VAD always wants to pull electricity from the wall. Okay? That's its preference. So this battery is just sitting here chilling, doing nothing, waiting for either for the lights to go out, right? Or for you to take this off.
Okay.
And when you take it off, it automatically, now 2 lit up, right? Okay? So you always know, just by looking at her controller, which side it's pulling from, okay? So,
Battery life is how long?
6 hours.
6 hours.
Yep, alright. So, if I put this back on, it's gonna toggle back over here. So, as you can imagine, this is just like, look, it looks just like a cord, like for a laptop, right?
So it doesn't get unplugged from the wall.
And if it did, you know what you would get? No, because right, there's always gonna be a battery sitting there. So eventually you'd get an alarm that was like, it'll come here in a minute. Bloop, bloop, hi. It'd be like if you were gonna change a battery, right? Or if you had a low battery, right? So you would know. So night shift, so 2 things. At night, or when she's sleeping, which is she's had a stroke, pretty much tries to sleep all the time, right? Okay? So if she's sleeping or going to bed, okay, at night, she should always be on the wall power. That way no one has to be going around like, hey, what is that? How long are the batteries going, right? Because you just know she's on wall power, right? So a couple things with wall power. You know you've got wall power if this green plug is illuminated. You see that? Green plug. Yep. So night shift nurse or day shift and she's taking a nap, right, is you're gonna look at the controller and just make sure, and that way too, you know that this thing's all plugged in and working right? Okay, plug.
That charges the battery?
Nope.
Oh.
Battery's just sitting here doing nothing.
How long does the battery last?
6 hours.
But how do you charge the battery?
She's got a charger in her room.
Okay.
Okay?
Really, we're not.
I'm gonna tell you exactly what you're responsible for. So we're just reviewing the system. You guys are peeing your pants, but we're just reviewing the system, right? Okay. I could pee. I was late, didn't pee. Oh, we'll figure it out.
Stretch break in 10 minutes.
Okay, in 10 minutes, all right? So, driveline. Can driveline ever come out?
No.
No!
It's the white one.
Right. And can one side of electricity come out? Yeah. And you just want to make sure that you've got 2 on before you take 1 off, all right? What happens if I take 1 off? Flips over the other side, right? So that's why it's safe to take 1 off, okay? It's always safe to take 1 off, all right? Do you take 2 off? No. Well, if you want to kill her, then yeah, just kidding. Okay, so a couple things with that. If the driveline came out or both sides of electricity came out, all you have to do is put it back and it starts back up. Right? You don't have to like dial in and log in and did it, right? Like get a retina scan. All you do is like put it back, turns back on. Okay? Number 1. Number 2, what do we know about what her heart's doing? It's pumping. So do you think she's gonna, like if her pump turned off, she'd be like,
No, it's not pumping.
right? No, she's not gonna be like, right? I mean, it's gonna make noise, right? So then what's the big deal? Why don't we want her pump to turn off?
Blood clots.
Blood clots, right? Because if blood's not moving, it's clotting. Okay? That's why, and it's sitting right next to the aortic root and the carotid arteries, right? So we don't want blood clot to form. So that's why we don't want her pump to turn off. If her pump were to turn off, she would just go back into heart failure. She probably wouldn't feel great, but she's not gonna be like, she's not gonna arrest, she's not gonna code, she's not gonna fall over, right? Okay, so don't be afraid of her. She's actually a lot more stable than if you think about a heart failure patient. Like the little old lady with AFib, be afraid of her. She's gonna F you up. This lady won't. Okay, that was number 1. Number 2, there are 4 pages, like if you were to read this, right, if I gave, it's like, okay, everyone go home and study this. Okay, there are like 4 pages of alarms. I don't really give a rip that you even know any of the alarms. Because quite frankly, if this because you would memorize, oh, there's a certain light and a certain sound, and then it tells you what the problem is. But in my experience, I've been a nurse a long time, no one reads with that. No one reads. No one reads when that's going on, okay? So, we all just, now we're all in reptilian brain, right? When that noise is going off, we're all in fight and flight, right? So, if I just tell you this, you're a lot more likely to like respond appropriately to a sound or something going on with that. You're always gonna check the same 2 things. And what are the same 2 things you're always gonna check? Is the let's do this. Oh, look, she handed it to me without the driveline in. Is the driveline connected to the controller? The answer here is no, right? So I take this red dot, everyone see a red dot on there? And I match it up to that red dot, and I stick it back in, okay? And, oh, probably fix the problem, right? Not gonna read, because I can't, my brain's not functioning in that mode, right? But I can check the driveline, if it's out, put it in, and if there's no electricity, line up that arrow, that white dot, push it in, it'll restart the pump, okay? So if you think about what your algorithm is, your critical thinking is, it is always gonna be the same no matter what the alarm is, okay? Check the driveline, check the electricity, have someone call us, right where you're doing that, right? That's like,
And the patient's okay, usually?
Usually.
If you're really quick?
usually. I have to say that there's only one patient I can think of who had really, really minimal EF that she syncopized. She would faint when her pump turned off. Everyone else is just like, some people don't notice it and some people are like, I feel funny. I don't feel so good, right?
Are they using an oxygen
No.
pump? And
No.
oxygen?
No, they're not sick. That's the thing.
I see.
They are not
Because
sick.
usually you check patients 3 or 4 and they're on oxygen all the time.
Right, but what do they say about this patient? Class 2. Right, like in the lower stages of heart failure, not on the end, right? So she's not here because of her heart failure. Why is she here? Stroke. which is one of the risks, right? So she's not here because of her heart failure, she's not here because her valve's not working, she's not here for any of that. She's here because she had a stroke, okay? Alright, let's take a quick, pee. Let's pee, stretch, and it's like 5 minutes. We'll come back.
You know where the bathroom is? I'll show you.
I've been here.
Oh, Mike, really good.
Oh, yeah?
Awesome silver pen. You see it? Oh, it's over by Elena. Elena, darling. There's a pen right by you that's mine. I have the patient, guys.
You look like
Hip, hip, hooray!
Oh, I think Katie worked with the other LVAD patient we had.
Oh, done?
Anyway, we go get a Diet Coke, cause, you know,
Still like Tim.
I need something good for me,
Just
haha.
keep that thing plugged in, that's all.
I will.
Да.
Betcha.
Дим. Слушай, мне написала сейчас Тина. Она спрашивает,
Yeah, I
когда мы
was supposed to work
приезжаем,
tomorrow, but I
надо
switched to
finalize
that Kai, cause he
вашу
wanted
так
it.
что позвоните Ире и
Yeah.
скажи,
So I'm
10
working Friday
числа
and
мы
Saturday.
съедем, я ей скажу, где 10 число, чтобы у нас время было собраться. Ну ты с ней поговорил вчера? Ты ей сказал, как?
Yeah. We got 2 admissions, that's good news.
Today?
Блин, да, человек мне написал вчера имейл, что мне ей сказать?
Well, it was 17 when I left the other day. I mean, I don't know if someone
Дим, я думаю, что надо переезжать, потому
discharged
что
I think if we
Не
was
знаю.
20, or are not
она же понимает, что мы подписали уже контракт. Чё она
Yeah,
тебе?
yeah, probably not. They have to get over that. They have to give us enough people. We have a new admissions
Так уже все, у нас контракт
lady, I
подписан,
guess
что она
now
хочет.
too. So hopefully she's gonna start bringing in more people. This is good. that
Ну
we
не
have
хочет,
people.
а на $600 поднять она хотела нам. И мы уже контракт подписали, мы уже людей подставляем, так тоже там не получается, знаешь? Они хотят и это, и то, знаешь, все вместе. Теперь мы будем по ним подстраиваться, нет. Но ты думаешь, они нам вернут 2800? Они нам не вернут 2800, которые мы отдали, понимаешь? Это Пападос из Аиры, понимаешь?
Let's see, there was a sign-in sheet, wasn't there? She took it, maybe.
Ну, наложено. Да, ну 2800 мы потеряем, понимаешь? Так а что мне ей написать-то? Она мне вчера написала имейл, она мне еще текст написала, что я же не могу имейл.